In this lecture, we're going to take a brief view of some of the clinical considerations related to COPD, and we begin with some of the more obvious signs and symptoms. And the first one here is acute respiratory illness, and this is indicated by an increased cough and the production of what's called purulent sputum. And so this is the production of an excessive amount of sputum, which comes from the excessive production of mucus. And so it is excessive and it is discolored. Some of the other obvious signs and symptoms include wheezing, which is a reflection of the obstructed airways, a feeling of chest tightness, and dyspnea, which is increased breathing, particularly notable when the patient is in a resting state. The limitations to airflow. This is not considered to be a type of condition that develops very quickly. It takes many years to develop. And one other sign that is detectable during auscultation, and so this is the audible production of noises detected through a stethoscope, is a crackling sound. And so physicians are looking or listening for these types of sounds that occur at the base of the lungs, which is a reflection of the air that is being attempted to be moved through obstructed airways. In terms of the history and the physical exam, the patient history becomes very important because it identifies very unique clues related to the person's condition and their previous exposures. And so, as indicated in previous videos, smoking is considered to be the primary causative agent, whether it's first or secondhand smoke, and a history of exposure to that smoke. Smoke that is generated from occupational or environmental exposure is also going to be an important consideration when taking a patient history, as well as any family history of the disease or related conditions to chronic obstructive pulmonary disease. Has the patient experienced previous hospitalizations? Have they experienced any particular treatments for it? And what, if any, of those treatments showed a degree of success for the patient? Those are important considerations before a physical exam is taken. And so there are many aspects to the physical exam, and two of the elements that are often examined is whether the person is generating what's called a productive cough, so the person is actually coughing out the excessive sputum, and dyspnea, so an increase in breathing, not just resting, but also on exertion. The diagnostic testing is carried out a number of different ways, and spirometry is the first type of diagnostic test, as outlined on a previous lecture, that is usually prescribed with a person suspected of COPD. Arterial blood gas levels are also very important to consider, because what we're looking for here is hypoxemia, which is low blood levels of oxygen. And why would blood levels of oxygen be low? Because of the obstruction within the lower respiratory tract, particularly through the bronchioles and the parenchyma, which are the lowest portions of the respiratory pathway in the alveoli. And if there is an obstruction in the airflow, there's likely going to be an obstruction in oxygen diffusion and carbon dioxide diffusion in the opposite direction. And this can occur with or without hypercapnia, which is high blood levels of carbon dioxide. And this usually manifests in later stages of chronic obstructive pulmonary disease, where the diffusion of carbon dioxide from the blood into the alveoli now becomes impaired, and that will result in an accumulation within the blood. In terms of x-rays, a person afflicted with chronic bronchitis should demonstrate a normal chest x-ray. So nothing notable in a person that is experiencing only chronic bronchitis. However, a person afflicted with emphysema will show some very clear signs on an x-ray. And those signs are larger than normal lung volume, which is a reflection of hyperinflation. And so recall that hyperinflation points to the increased amount of air trapped within the airways, as well as a flattened diaphragm. And so with this increased volume, this requires space of the lungs, and that pushes inferior on that large dome-shaped muscle that exists inferior to the lungs. CT imaging is sometimes indicated. It does provide better resolution and imaging, but it's not routinely used. And the reason that it's not routinely used is because the treatment and the therapeutic recommendations would not differ from CT imaging. And so the x-rays, a standard x-ray, along with an assessment of arterial blood gases, spirometry, and the patient history is sufficient to determining and diagnosing if a person has COPD and the stage of that COPD. So on the right-hand side of the slide, here we see an X-ray image of this person's lungs here, and so this is considered to be a healthy image. And on the right-hand side, here we see a person afflicted with emphysema. And what we see here, notably, are the larger lungs, so that indicates hyperinflation, and a diaphragm muscle that appears to be more flattened as opposed to a more dome-shaped appearance here on the left-hand side. And as outlined in a previous lecture, that the problem with the diaphragm being in a chronically shortened state is that it becomes more mechanically inefficient to produce force, and as a result, the diaphragm muscle will have to be activated to a greater degree to produce force if it is in that weakened state. So this ends this lecture on clinical considerations.